Good day, ma'am. This is Maria Erica Joy G. Icaro, and I will report my part, the nursing responsibilities in gastrectomy. First is teach ways to prevent the pain and reflux. Next one is instruct the patient that after the surgery, patient's stomach won't be able to hold as much as it did before surgery, that need to have 6 or more small meals a day instead of 3 main meals. This will help to eat the right amount of food even though your stomach is a smaller organ. And next one is instruct the patient to chew the food well. This makes it easier for the body to digest the food. Next one is instruct the patient to avoid spicy and peppery food soon after your surgery. Instruct the patient aim to drink about 8 to 10 ounce glasses of liquid each day. Avoid carbonated or the fizzy drinks if they make you feel full. And next one is my video discussion and presentation. First, I will show po the picture of the total gastrectomy of the procedure po. Before I show po the video. So for the step 1 of the procedure of the total gastrectomy, first is the patient needs to place in supine position with both arms straight against the torso. And for fork placement, a line is drawn from the umbilicus to the xiphoid, which is divided into 3 equal parts. The 10 mm camera port is then put at the level of the candle third part, 2 to 4 centimeter from the midline, and then open. The Hassan technique is performed to establish. And then the next step is division of hepatogastric ligament. So for this one po, is placed underneath the left liver lobe. So use the endopalpar tract as it also helps us further up in the procedure. When the stomach is lifted up for the restographic resection, the assistant retracts the stomach quadrantally and the surgeon divides the hepatogastric ligament. The line of transection is below the left lobe of the liver and on the top of the candidate lobe. And after the hepatogastric ligament is divided, and if adequate retraction is maintained, the right crust and its white line can be visualized by the surgeon. And the dissection is continued perpendicular until the esophageal hiatus. And then for the step 3, the division of gastrocolic omentum and short gastric vessels. So the patient is positioned in a slight reverse Trendelenburg, which allows the transverse colon to descend. And an entry point to the lesser sac is identified. Usually, it is easier to start towards the left side of the patient. We stay on top of the transverse colon with care not to injure the transverse mesocolon basiculate, and the omentum is not divided into and block, as we experience that the bulk of omentum connected to the stomach made the exposure for gastric modulation more difficult. And then for the step 4, division of left gastric. The gastrocolic omentum that is connected to stomach after dissection of the gastrocolic ligament is split anteriorly between the stomach and the liver. And then for the step 5, celiac trunk and splenic artery lymphadenectomy. After completing the step 4, the surgeon continues further posteriorly to harvest the celiac node and continues on the superior border of the splenic artery to obtain the splenic nodes And this step must be done with great care as the splenic artery coils along its trajectory and can be easily injured. And then for the step 6, common hepatic lymphadenectomy and right gastric ligations. So for this step, the stomach is placed again in its natural position and retracted downward. The endopalmar tract is placed under the liver again. The previously identified hepatic artery node is found following the superior border of the common hepatic. The origin of gastroduodenal artery and proper hepatic will be found. And for the step 7 is the hiatal dissection. This dissection vein along the right crus is found again and restarted posteriorly towards the left crus until the aorta is visualized and then continued at last finalized on the anterior aspect. And then for the last step of the procedure of the total gastrectomy, this is the duodenal dissection and gastric resections. For this one, the remaining gastrocolic omentum located toward the duodenum is resected. During this step, the right gastroepiploic pedicle is visualized, dissected, and ligated with the use of hem-o-locks. The inferior and superior border of the duodenum is cleared and blocked with the inferior and superior pyloric nodes, and a retroduodenal passage is created to allow passage of the stapler. So after po nun, i-show ko naman po yung video ng total gastrectomy. So here's the procedure of the total gastrectomy. That's all for my part po, ma'am. Thank you po.